Today we will present a case study regarding a 53-year-old female. Her presenting complaint is recent arguments with her partner regarding low libido. She is postmenopausal 4 years and currently on HRT with transdermal estrogen and progestogen. She lives with her husband of 15 years, 2 children who are no longer dependent. She works as a cashier and keeps active by playing tennis. On examination, her blood pressure is 138/90 and her BMI puts her in the overweight category at 26. Now let's discuss what causes low libido. Testosterone is considered a male sex hormone, but testosterone is not just a guy thing. In fact, the ovaries produce about 25% of testosterone in women, and by the time a woman reaches menopause, blood testosterone levels are about a quarter of what they were at their peak. It has been suggested that hypoactive sexual desire disorder develops as a result of diminished androgens such as testosterone, and this is due to a functional decline in production either because of menopause or due to the surgical removal of the ovaries. HSDD is defined as a persistent or recurrent absence of sexual fantasies and desire for sexual activity, and this can cause marked personal distress or interpersonal difficulties. However, there are other things that can contribute to low libido, and there's some other differential diagnosis. And we have to think about physical, medical, psychological, emotional, hormonal, or relationship-related factors. Let's discuss a few of these. So vaginal dryness and painful sex contribute massively to the woman's participation in a sexual activity. Underlying health issues and addiction to alcohol, smoking, or illicit drug use may affect or contribute to difficulty reaching climax. Some prescription medicines, such as antidepressants, can affect libido, and definitely hormonal changes. Psychological issues such as stress, anxiety, depression, fatigue and exhaustion. And an important issue would be thinking about body dysmorphia and poor body image, because women are hugely affected with this with their changing menopausal body, such as central obesity and weight gain. Relationship issues such as lack of emotional support or connection, unresolved fights, and another one to consider is the change in the partner's sexual function or health. So, how do we manage this patient? A full and thorough history is required to explore all the contributing factors. In addition, a biopsychosocial model may be used to identify any modifiable factors that can be contributing to the reduced sexual desire. Laboratory blood tests may help exclude underlying conditions, although they are not required to diagnose HSDD. Testosterone in females can be inaccurate, especially when low, because when testosterone is bound to the protein, sex hormone binding globulin, it makes it difficult to measure the free fraction. Nonetheless, we do test testosterone and SHBG levels because they can be useful as a baseline when we're considering testosterone therapy or initiating testosterone therapy. DHEA is the most abundant sex steroid hormone in women, and low levels can be a sign of adrenal insufficiency. We should always check thyroid profile and prolactin to exclude endocrine conditions. To make the diagnosis, use of the decreased sexual desire screener are recommended. This is quick and easy and requires no prior training, as it only involves 5 yes or no questions. If the symptoms persist for 6 months or more and we cannot find any identifiable modifiable risk factors, then we can make a diagnosis of HSDD. Now, how do we treat these patients? So the International Society for the Study of Women's Sexual Health published clinical practice guidelines in 2021 for the use of systemic testosterone in treating hypoactive sexual desire disorder in women. These guidelines recommend considering testosterone therapy after ruling out other causes. So we must make sure that women have adequate estrogen before considering other therapies. Changing to transdermal estrogen can increase the amount of free testosterone without the need for testosterone therapy. In Australia, we can actually initiate a testosterone cream, Androfem. It has TG approval and it's applied daily to the skin, either the thigh or buttocks, in small measured amounts. And this is specifically designed for postmenopausal women with HSDD. We can offer sexual lubricants and moisturisers, and these can help address issues like vaginal dryness, and that can significantly impact sexual pleasure, but these products do not directly affect libido, but can improve comfort during sex. Other options are cognitive behavioural therapy, or if depression is present, antidepressants that do not cause sexual dysfunction may be considered. Other drugs are available in other countries, but not here in Australia. So in conclusion, there is no way to measure libido, and it varies within individuals. However, a healthy libido is often considered an important part of overall well-being and quality of life. It's therefore extremely important to consider this when assessing and treating menopausal women.